It's a busy time, not just for the NHS, but for health systems globally. So we're very lucky to have Matt Hancock here as the Secretary of State for Health. Matt's going to talk for about 20, 25 minutes or so, and then we'll have a round of questions. So, Matt, go.
Well, thank you very much. Thank you very much, Nick, and it's wonderful to be here in this extraordinary setting and at this vital conference. And of course, the whole country is concerned about the developing situation on coronavirus, on COVID-19, and we're doing everything reasonably possible to keep the public safe. I want to start by praising the exemplary response of my officials, Public Health England, the whole NHS, and the wider health system. And I think you'll all agree with me, and everybody in this room will agree with me, about the brilliant work of the Chief Medical Officer, Chris Whitty, who's set out the plan to contain, delay, research, and mitigate the virus. Now, that plan will be driven by the science and guided by the expert advice, which is marshalled by Professor Whitty. And tackling this virus is imperative, and it's taking up the overwhelming proportion of my time. But while we grapple with the virus, I'm absolutely determined that that must not take our eyes off the long-term challenges that we also need to rise to, and the long-term changes that we need to make to our healthcare system to make it the best that it possibly can be. And that's what I want to focus on today. Delivering our manifesto commitments, of course, including 50,000 more nurses and 40 new hospitals. It was great to see the news this morning of over 8,000 more nurses in the NHS over the last year. And addressing the priorities of people, infrastructure, technology, and prevention that are the long-term priorities of the department. So at this conference today, I want to ask this big long-term question and formally set the health system a new goal. The question is, how do we ensure that in today's world that there is always public confidence in the NHS? In a speech to the Royal College of Nurses in 1948, Nye Bevan gave a famously gloomy assessment. He said, "We shall never have all we need. Expectation will always exceed capacity. The service must always appear to be inadequate." Now, I'm generally skeptical of those who say this time is different, but I want to argue today exactly that. My argument, and I appreciate this is quite a dangerous thing for a health secretary to say, especially at a Nuffield conference, is that Bevan was wrong. The service does not always have to appear to be inadequate, either for patients or staff. This time can be different. And the reason is that today's technology, unlike previous technological advances, allows us to do more in healthcare at lower cost. Now, I don't think that's ever been true before in the history of the NHS. There have been amazing advances like heart transplants and chemotherapy that have allowed us at greater cost to save more lives. And this is good, these are good technologies. But the power of modern technologies are that they allow us to improve outcomes and reduce costs at the same time. Radiology in the cloud is cheaper and faster than a system based on couriers and CD-ROMs, for example. In fact, Chris raised in the Q&A examples of improvements that also save cost. And while technology on its own solves little, technology that clinicians want to use because it meets their real-world needs, designed with their input, done with them and not to them, this has game-changing potential. And we know this because we can see it right across every other part of the economy, and we can see it in parts of the NHS. Get it right, and by the end of the decade, we can have an NHS that functions as a platform rather than as a set of loosely aligned, disconnected, incommunicative silos. An NHS focused on preventing sickness, not just treating it, enhancing life, not just prolonging it, where staff do more of what they came into medicine to do, caring and treating and healing the human things that a computer can never replace. And we can do that because we've removed or improved the grind of routine process. And to make that happen, I think we need to change the way we think about how change happens in the NHS. Now, policy makers love the idea, and I can tell you it's tempting. Policymakers love the idea that change is something you do with a top-down reorganisation and big bang structural reforms. It's why the last couple of decades are littered with failed attempts to transform the NHS by structural reform from on high. But guess what? It's not all about us policymakers. The answer to better healthcare lies less in complex reforms cooked up by the centre. We've tested that idea to destruction. It lies in millions of incremental improvements carried out at every level of the service, every day, by people who feel and are empowered to make things better in pursuit of a common goal. The small tweak to a process that improves patient flow. The trust that saves hundreds of hours of clinical time with access to real-time test results, for example. The streaming that manages record demand on our A&Es. These are the things that transform the NHS. Now, they don't happen on their own. They require strong accountability. They require the right data so the system can constantly learn about what works. They require resources, including, of course, the record £33.9 billion funding increase that yesterday passed through the House of Lords and will be enshrined in law. And it requires trust. And this is something about culture. Trust in clinicians to make those improvements, trust in local systems to serve their population as a whole, trust in everyone who works in the health service to seek out and make these improvements, and trust in patients to play their part in their own health. Now, this is how change happens in big organisations like the NHS. But this method of marginal improvements requires people also to have a common mission. And my case is that we must free people up to innovate. And in all the big organisations where freeing people up to innovate has worked, it's where you have a common goal. And for me, I think this is something that we can achieve in the NHS because it's so clear what the common goals should be. Today, I want to set out 2 goals for our healthcare system. Big picture goals, not just for the front line of the NHS, but for the system in its broadest possible sense, the department, the central bodies, social care, and the ecosystem that surrounds us. One is a clinical goal, the other a goal of user experience. Both are equally important. I want to stress that. I think they are equally important, and each reinforces the other. Now, the ultimate clinical goal, I think, is to increase healthy life expectancy in this country. As a nation, we've set the goal of 5 more years of healthy life expectancy by 2035. Not just adding years to life, but life to years. But this clinical goal is not enough on its own. Everyone in the NHS goes to work to serve patients, not just to treat them. Indeed, the whole NHS serves our country just by existing, by giving peace of mind to everyone, even if you very rarely use it. So the second goal I want to set is to increase public confidence in the NHS. Confidence that the NHS will always be there for us, that the NHS will look after us and care for us with dignity and respect, that it'll treat me as a person with a history and a future, not just a series of unconnected, siloed clinical episodes. Now, public confidence is not the same thing as public support, important as that is, or even public satisfaction with the quality of an individual treatment. These things are smaller. How you're treated at reception, whether the staff have pride, whether the hospital is tidy, whether somebody explains to you what's happened and keeps you properly updated. These things might not matter from a strictly clinical point of view, but they should matter to an organisation paid for entirely by the public, which exists to serve the public. And I want to draw a parallel to what's happening on coronavirus right now. We've seen this approach working. It is an explicit goal in our response to coronavirus, not just to tackle the disease, but to maintain public confidence. And we should take this attitude to health services in normal times too. In the second quarter of 2019, the NHS received 50,000 written complaints on various subjects. I don't know if you know what the one subject that accounted for the largest proportion of complaints was. Communications. It wasn't waiting times. It wasn't the clinical and medical treatment. It was communication. So I'm setting the NHS the challenge that it should be as good at process and admin as it is at medicine. That if you've got a chronic condition, you shouldn't have to carry a ring binder of notes from one appointment to the next because your provider can't access your full medical record. That we shouldn't be asking you to make a stressful journey into hospital when you could get the same result at home using modern methods. That when you're notified of an appointment, that notification should never arrive after the appointment was meant to take place. That is one of the most frustrating things, and it happens right now in the health service. The National Health Service must be just that. National health and the service. Not just a hospital system, but a service for the nation's health. So I want to take each of these three in turn, because they are all important. Let me take the national first. So if we step back and ask why the NHS is so important, one of the reasons is that the NHS is part of our national identity. We love it because it's always there for us unconditionally, through some of the best moments in life and through some of the worst. This is what maintains the public's support for the NHS, which is so important. As the Prime Minister puts it, it's like the whole country figuratively gathering around your bedside when you fall sick, doing everything it can to make you well again. But that shared ideal is one of the few things about the NHS that is truly national. Because the NHS is not some centralised command and control state like Bismarckian Germany, and I can assure you as Health Secretary, I know that. It's more like the Holy Roman Empire, a story of fragmentation and duplication and high levels of regional variation. There's no single national back office, for example. Local providers have their own teams and systems for every conceivable non-clinical activity, from booking appointments to registering patients to organising staff rotas to ordering medical supplies, with massive duplication of effort. Nor is there a national data architecture. I first discovered this through personal experience, like many people do. My sister had a very serious accident. Some of you may know about this. Just before I became Health Secretary, she had a near-fatal brain injury. She received amazing life-saving support at Southmead Hospital in Bristol. She underwent 6 months of rehabilitation. And when she went back to her GP to get approval to reapply for her driving license, despite having known her all her life, her GP had no idea about the injury at all. No record, no details. And that is not a unique experience. It's an everyday occurrence. So when I say national, there's another aspect to national as well. And this has been highlighted acutely by the report by Michael Marmot this week. We have a checkerboard of local variation. Look at life expectancy. I think this is a very serious problem. A person born in Wokingham can expect 72 years of healthy life, just down the road from here. 72 years. In Nottingham, it's 54 years. In Blackpool, 1 in 4 women smoke during pregnancy. In Westminster, it's 1 in 50. So this is the first part of our project. In the 2020s, we must make it our mission to put the national back into the National Health Service. At the patient-facing end of the service, that means levelling up across healthcare, ending some of the postcode inequalities. So, for instance, your chance of seeing a GP doesn't depend on where you live, not just delivering the 50 million GP appointments, extra GP appointments that we committed to in the manifesto, but making sure they're focused on where they're needed most. Being a national service means having consistent standards that all patients can expect. You want local variation where there's local variation in conditions, and it'll be a central task of the new integrated care systems in every part of the country to take into account local conditions when improving the health of their populations. But we need less unwarranted variation in both commissioning and delivery of services. Why should 3 cycles of IVF be allowed in some parts of the country and some other parts offer none? A local part of the NHS deciding it's okay not to offer IVF with no accountability, it's absurd, it's unacceptable in a national system. It also means, national also means, having a platform approach to the way we deliver some of the things like the back office. Now, what do I mean by that? Building wants at the centre where it makes sense to do so suppliers and commissioning bodies don't have to recreate the plumbing each time. Look at one of the things I announced over Christmas, one of the most popular things I've said as Health Secretary. Maybe a low bar. The NHS login, our National ID Assurance Platform. It takes many minutes to log in to the many, many different systems. And the number one best thing I've had feedback on from clinicians is the NHS login once announcement. And there's a whole new growing ecosystem of this sort of service, from GP appointment bookings to remote consultations to digital maternity services, all of which require you to prove who you are. And we need to make sure that we do that simply and we do it once. We're also looking at a consistent way to identify staff across the system. But the most impactful and clinically useful platform we can create is a national data architecture for the NHS. It's a massive opportunity for patient experience, clinical excellence, and the next generation of research. Fixing this is not, repeat, not about building a single giant centrally owned patient database in the basement of NHS England. Instead, it's about creating an architecture so systems can talk to each other and so data can be safely accessed where it's needed. The whole country. We need the whole country to be covered by local shared care records. We need those shared care records to be able to speak to each other with common standards. We need clinicians to have the trust and confidence to use them. And I can announce that we've just published our new draft digital health technology standard designed to make it easier to commission great new digital health services. It requires developers to follow these standards on interoperability if they want us to buy their stuff, and there's much more to come. And today we're kicking off our engagement on our tech plan for health and care, setting out how technology will support the delivery of the NHS long-term plan. And this includes establishing what good looks like in all forms of tech-enabled care and clarifying who pays for what and what we need to do to drive these improvements. And I'd urge all of you to get involved, everybody, whether you're interested in technology or not, because developing this plan should not be left to us at the centre. It is too important for that. Now, there will never be a big bang moment when we flip the switch and say the problem's solved. Like all genuine improvement, this is an incremental, iterative process. And done right, this approach must be entirely embedded in evidence. It's about what works. And the evidence is abundant, it's strong, and it's growing. Bringing technology in the NHS into the 21st century works. Modern use of data works. Ignoring that evidence is as much of an error as blind faith in any technology. So I'm determined to drive this agenda, because if we get the technology and the data right, we can do incredibly powerful things. So that brings me then onto my second letter. Health. According to the best evidence we have, only about a quarter of what leads to these longer, healthier lives is the result of what happens in hospitals. The remainder is down to genetics, the environment, and the lifestyle choices that we make. As a healthcare system, I think we actually have quite a strong track record on both improving some of the broader determinants of health, the inputs, and the health outcomes. So smoking rates, I talked about the local differences in maternal smoking rates, but smoking rates have halved in the last 35 years, and we now have one of the lowest rates in Europe. We lead the world in managing long-term conditions like diabetes, with fewer than 1 in 1,000 patients being admitted to hospital in any given year. Deaths from cardiovascular disease have halved since 1990. Cancer survival is at an all-time high, and male suicide at a 31-year low. We also have some of the finest public health officials in the world, and I'm very grateful for the work that they're doing in response to COVID-19. But we can and must go further. For most of its 70 years, the NHS has been focused on curing a patient of single illnesses, putting ever more funding into big acute hospitals. This has had an impressive impact on lifespan, but as it enters its 8th decade, as we've seen, those increases in lifespan have started to slow. And it's clear that the NHS also needs to focus more on health span, the number of years a person can expect to live healthily and independently. And that is true for the wider health system too. Prediction and prevention are mission critical to delivering these 5 extra healthy years of life. It's partly about smarter use of the way we use NHS resources, things like dedicated alcohol care teams in hospitals, where they have the highest rates of alcohol-related admission, or much more support to help people quit smoking, and making sure that our screening programs are radically improved so they're easy to use and no one gets left behind, and putting more resources into primary care, community care, and asking our army of pharmacists to do far more to keep people healthy in the first place. Like recently, rolling out non-drug therapies through social prescribing right across the country. So this approach is all about recognizing that not all the answers are in the NHS. We need a cross-government action on air pollution, for instance, properly insulated homes, urban design, supporting cycling and walking. And again, people have been talking about this since the 50s, and why is this time different? Again, I think there are big things that mean that we can move faster. Firstly, we have more and better information than ever before, and a lot of this is distributed outside the system on Fitbits and smartphones and other internet-linked devices. And we're also creating increasing amounts of genomic data, including our project to sequence 5 million genomes. That is all data that helps us to fill in the big gaps. And there are still big gaps. I just want to pick out a couple. Big gaps in our knowledge about what works and for whom. Take drug responsiveness. A few years ago, Professors Eric Topol and Nicholas Stork put out a study showing that the responsiveness, the intended clinical response of the top 10 drugs by gross sales in the US, overall, 75% of patients receiving those drugs did not have the desired or expected benefit. It ranged from 1 in 5 patients with schizophrenia deriving a benefit from the market-leading schizophrenia drug to only 1 in 16 patients with MS. This is known as the number needed to treat, which means the number of patients you need to treat to prevent one additional bad outcome. Until we can safely use all the data that we hold about individual patients, that number will remain stubbornly high. Cancer is another example where we're making a huge amount of progress on this. The major trials funded by NIHR show that many people given surgery or radiotherapy for prostate cancer will do no better than those without treatment. But we don't know which people in advance. But increasingly, we can marshal all the data about a patient and then treat each patient as an individual, finding the treatment that's right for them, bringing the number needed to treat closer to 1, saving the NHS and patients the cost and pain of unnecessary treatments. So that's the first big change that we can harness. The other big difference is that we now have the computing power to do the marshalling. Already, AI can perform as well as human radiologists at detecting certain cancers. Let's embrace that. AI recently developed at MIT found new antibiotics for tackling drug-resistant microbes. This is why we've set up a 250 million AI lab in the NHS to identify and, crucially, to scale the most promising technologies and to get the regulation right. And by the end of the decade, we need doctors to have all the relevant data and the training to use them about the patient in front of them. Not just the patient's full health record, but the genomic data and any self-generated data they want to volunteer and data on similar cases. And we need to have the AI and the other decision support tools to process that and need to have them doing the right training to understand it all. It can be done, and it's being done in the most advanced parts of the NHS. We need to turn the NHS from a national hospital service to a health service, making sure that we're focused on the health of the patient. And that finally brings me to the third thing that I want to say. The NHS. The S is for service. I've drawn a deliberate distinction between health and service, between clinical outcomes and public confidence. To help me explain, maybe I could tell you a story. I mentioned the problem of different care settings not being able to access patient records. At Barts in East London, they've solved that problem for chronic kidney patients. It works like this. The renal unit at Barts have a data sharing agreement with 160 local GP practices, allowing consultants remotely to view full GP records with patient consent. It means they can see a patient's creatine levels over time, which of course is a crucial indicator of kidney health, as well as the medical history, comorbidities, past hospitalizations, and so on. Following reviews of the notes, the consultant records her advice on the BART system and the practice gets a notification. The small minority of patients who need further investigation then get triaged into traditional face-to-face clinics. The vast majority of patients don't ever have to go to the hospital, and they get reviewed much faster. Before the virtual kidney clinic started, the average time from referral to the first outpatient appointment was 64 days. Now the time between referral and assessment is less than a week. It's too early to say if it's improved clinical outcomes, but that is not the point of the exercise. The point was to improve the service. Because if you're in a nursing home with chronic kidney disease, then getting into central London to go to Barts can be a real ordeal. And the virtual clinic improves patient access to the NHS while removing a whole rigmarole of arranging transport and travelling in and worrying about tube delays and tracking down missing referral letters and sitting around in waiting rooms when you're not very well. Not only did patients enthusiastically consent to their records being shared, but like all the best service improvements, they were amazed that it wasn't happening already. There are loads of other areas where we can make the service better. And as I said, the medical advances in the NHS are amazing, but the process advances are far too slow. The Royal Mail should not be the default mode of communication between patients and providers. Patients should have access to their own medical records. We know it improves the quality of the data where they can spot a mistake, and it can be life-saving. In Southampton, they gave prostate patients real-time digital access to their PSA results as soon as they come out of their lab, unmediated by a physician. It's incredibly popular, even amongst older men who don't necessarily have the digital experience. And the reason is that people want to manage their own care. And wherever possible, healthcare should come to you before you have to go to healthcare. This is not as radical as it sounds. And I know that there are some people who scoff at this agenda. But let me give you one example that we now take as read. 30 years ago, you had to go to a doctor to get a pregnancy test. Now, of course you take the test yourself before you go to the doctor. Of course you do. And it's not just about the technology. The capital building program that we've got is not just about those 40 new hospitals, it's about meeting rising demand and ensuring the best possible service for patients as well as clinical outcomes. Because patients don't only care about the clinical treatment, they care that the hospital looks smart, that it's clean, that staff are friendly and well motivated, that the food is good, and crucially, that they're told clearly what's going on. These are the things that matter to patients, and they need to matter to every single person in this room and every single person who works in the service. For the NHS is a service, or it is nothing, and we are at the service of the nation. At Great Ormond Street, they now note a child's favourite food or football team to help the staff make a connection with the child. I love that. A simple change that can make an incredibly stressful experience just a little bit easier. So there you are, the NHS, our national health and service. And to entrench and underline the central importance of that sense of service, that's why I'm setting today the explicit goal of raising public confidence in the NHS. I think overall we have a hugely ambitious and exciting agenda. Everyone here has a part to play. It's first and foremost about the people, about how we get the most out of our people, and about how we get more people and how we motivate and incentivize and support and train. And I'm very proud to see the staff survey results moving in the right direction. And it's brilliant news that we've increased the number of nurses in the NHS by over 8,000 in the last year alone. And with the people plan, we'll set out yet more about how we can support every single person in the NHS to reach their potential. It's about infrastructure, fixing the roofs, getting the modern buildings that we need to deliver modern services closer to home. It's about prevention of ill health to reduce pressures on the system. And yes, it's about technology, because there are historic problems that we can now fix by bringing the technology of the NHS into the 21st century. We all know that demand and expectations are rising. We can't afford to stand still. We must reshape our health service to harness the resources that the modern world can offer and deliver a national health service of which we can be proud. Thank you very much indeed.
Whichever you prefer. Whichever you prefer. Matt, thank you very much indeed. That was very wide-ranging. Another goal for the NHS to achieve. Tiny bit of me might at some point ask, how are you going to measure confidence in the service?
Yeah.
But before we do that, can I just say, I'm aware there's a good sprinkling of my old trade here, the hacks, so to speak, and they are going to want to ask about coronavirus. But we are here to do some other things. I promise you we will come to it, but first of all, we'll do some other things.
Yeah.
Can I just pick up a couple of points from the speech? You were suitably scathing about Big Bang, top-down reorganisations.
Yeah.
But there is a proposal for some NHS legislation.
Yeah.
So can we take it from that you have no immediate plan to make integrated care systems statutory? And secondly, there's a lot of reports that the government would like more powers of direction over NHS England, greater control. What have you not been able to do without that control so far?
Well, I don't think that that designing system improvements from Whitehall with this Big Bang approach is the way that you improve service delivery on the ground. The way you improve service delivery is by empowering people on the ground to make incremental improvements and listening to them about improvements that need to be made. So with the bill that was announced in the Queen's speech, the primary goal of that is to reduce some of the burdensome bureaucracy that previous reforms have put in place, that for instance, disallow the integration between primary care and community care. People often sitting in the same office, not allowed to directly communicate with each other for legal reasons. And also to empower the ICS principle of population health. But I want that to be a bottom-up driven process. We've already got many parts of the country where ICSs are working very well, but I don't want to say everybody will be will move at the same pace. People need to move at the pace that works for that system. Right. The ICS principle is absolutely where we're going, and we've got to get the powers right for that. But it is but it's got to be a bottom-up type reform that goes with the grain of how we allow people and help people and remove the barriers to people making improvements locally. Right. And does the Secretary of State need more control over the actions of NHS England? Well, there have been questions raised about when you merge NHS E&I, for instance, which were designed in the 2012 Act to be counterbalancing forces within the system, and they've been merged in order to reduce the bureaucracy. Yep. But the primary goal of this piece of legislation is to remove the burdens and the barriers that get in the way of people making the incremental changes on the ground. That is the way I think that all big organisations improve. Yeah, great. One of the priorities you mentioned in your speech was prevention. We still don't know what the public health grant is going to be for the coming financial year, let alone for a longer period. It has been squeezed badly. So if prevention is a priority, in a sense, where's the beef, so to speak? Well, the beef is in a very broad agenda, of which the public health grant is a small piece. The public health grant is increasing this year, and we'll get the exact allocations out very soon. But actually, prevention is a much broader agenda, as I tried to set out. The reducing air pollution is part of the prevention agenda. That doesn't come through the public health grant. It comes through DEFRA policy. Yep. Improving housing is and making it more the design of housing more pro-health, and in particular more pro-strong mental health. Yep. That's a prevention agenda. So, of course, the public health grant is important, but it is a small part of the overall prevention agenda. Right, right. And could I just come back to one other bit, which is, this is entitled The Government's Vision for the NHS and Social Care. Yeah. Are care workers skilled workers? Oh, I think they are, yes. So how will they be able to come in under the current proposals for immigration control? Oh, well, the proposals allow for points-based system, and we've got to set out how that'll work. The important thing about the immigration system that we're bringing in is that, and I suppose this is a consequence of leaving the European Union, is that it's the UK government that'll be able to decide how to set these rules. But I'm acutely aware of the.
But the way they seem to be set at the moment is unlikely to allow immigration for that class of worker.
Well, you've seen how we've responded to the challenges of needing to increase employment in the NHS and bring in more people, nurses and doctors in the NHS with a specific NHS visa. And the Home Secretary and I have an ongoing dialogue about how we can make sure this system will work for social care. But I can't prejudge that.
But there is an ongoing dialogue. There is an ongoing dialogue. Right. The other thing is, of course, the Prime Minister promised to fix social care once and for all.
Yes. That's
and
right.
we've all been waiting for about 30 years for something.
Oh, I know. Look,
and can I just make one point? You know, the Do Not Reform, the Care Act, is already on the statute book.
Yeah.
You start with that now.
Well, we had a debate in Parliament on Tuesday about this, and there I said that the failure to deliver reform to social care hasn't been a failure of policy making. It's been people not recognising that this is an exercise of political economy. And we've got a plan, firstly, to seek consensus and to start doing that within 100 days of the election, and we are, I think, on day 78. Secondly, to put more money in the short term, and we've done that, increase the spending power next year by £1.5 billion. It's a 4.4% overall increase in local authority spending power. And then third, to ensure that we have a system in which you don't have to sell your home to pay for care. And I think that's very important for maintaining public confidence in the reforms that we're going to propose.
If you stumble across the cross-party agreement bit, you are in the government with an 80-seat majority, so
it's
decide what is right.
Seek cross-party consensus.
Right. Okay. Fine. Let's open it out. Could we just save coronavirus questions for a moment? Yes. Sorry, the lights are in my eye. I can see a hand, but not who.
Thank you very much, Secretary of State. Anne-Marie Rafferty, President of the Royal College of Nursing. It might all be dangerous to quote Bevan, because at the beginning of the National Health Service, he did describe the shortage of nurses as approaching a national disaster, which undermined the very viability of the NHS. That was in 1948. And of course, we do have a national shortage of nurses, and there's a very ambitious target, and I think would speak for Donna as well on this, that the Royal College of Nursing is delighted to be working and helping to provide that. But in my day job, we did some research that also demonstrated that a key way of building patient satisfaction and converting that into public confidence in the NHS was actually recruiting and ensuring sufficient staff in the service itself.
Yes.
But it's not just actually registered nurses which we need, it's the proper skill mix and indeed the actual shape of the workforce, because at the moment we lack sufficient progression of senior nurses into the top position. I mean, there's just far too few coming through the system to be able to support the hordes of nurses beneath them, as it were. So it's building that support structure. So 50,000, is great to help you to get there, but that's something of a kind of down payment to help deal with the vacancies. And we've got to build in the long term beyond that. And I just wondered what your thoughts were for the beyond the 50,000.
Okay,
brilliant. There's a Lyndon Johnson had a phrase. He said, in politics, people only ever ask, what have you done for me recently? We only set out the 50,000 target in November, and it's great to have the RCN asking for more. Of course, we've got to deliver the 50,000, and we will, and we're working together on it, and I'm very excited about it. But I totally agree with the premise of your question, that is only part of the workforce answer. The people plan is intended to, and will be, broad right across all elements of nursing and all elements of the people who work in the NHS. I found it utterly astonishing that when I arrived as Health Secretary, there wasn't a Chief People Officer for the 5th largest employer in the world. Absolutely nuts. And in the past, people planning, workforce planning, has been some sort of top-down statistics exercise, as opposed to working with the 1.4 million people who we've got. And so all of that is changing, and I think that Prerna is doing a brilliant job as the first Chief People Officer. I think it was telling that we had to go to the United Nations to hire someone, because it means that she can work with all the different constituted parts of the NHS using her diplomacy skills. And but the nursing, the 50,000 more nurses is incredibly important. As I say, 8,570 announced this morning. Good start. But if you want a proof point for me demonstrating that I agree with you, it is that when we set the new bursary up immediately after the election, we did not set the bursary just for nurses, but we set it for AHPs as well. And that, in a way, shows our commitment to this broader agenda.
Great. Nick Black. And
Nick Black, London School of Hygiene. I'm delighted to hear your enthusiastic support for innovation and recognition that in 1.5 million health and social care workers out there, staff, got brilliant people with entrepreneurial skills to really innovate. And to hear it from the Secretary of State saying you will empower and support that was really welcome. I share your view that that's how the transformations are going to come, not by top-down levers. Later in your talk, as particularly around under the area of national, I got a strong message about much more traditional command and control approach, an almost abhorrence of variation between different parts of the country.
Yeah.
How do you reconcile that?
Yeah, that's a great question. And I'm very grateful for the opportunity to set it out a bit more. And I used IVF as the example. I think that the best way to run a large organisation like the NHS is to have national standards that everyone must meet, and then huge amounts of empowerment to the local in delivering on that. Of course, we do this, for instance, in every Royal College, which sets clear national guidelines as to how any particular practice area of medicine ought to operate, and then, of course, gives the clinician full professional freedom on the ground to get on and implement those as they best see fit. There's a wonderful quote which says, don't tell somebody how to do something, tell them what you need done. And so these standards should be thought about. So IVF is the best and most egregious example. It is not for a CCG to decide whether you should have 0, 1, 2, or 3 rounds of IVF available. The idea in a democracy with a national service that a local body which does not have democratic legitimacy, it's different when a council does it because they are elected locally, they should make what is in effect an allocative decision between different parts of the country. And there are other examples on that. I think some of these things are already set nationally, others ought to be. And then there's another part of what I was trying to say on the national, which is about more about outcomes rather than policy, where clearly we need more focus in some areas, and in particular some quite strong intervention, for instance on maternal smoking, which I think is something that is unbelievable in terms of the inequalities that it leaves behind in the next generation too. So what I was trying to say is that what we should do nationally is consider and set national standards, and then we should leave local areas to do their very best within those tramlines.
Right. Over there, thank you, Anita. I'll take one more general question, and I will come to Karina.
Anita Charles from the Health Foundation. I wanted to pick up the question of the social care workforce, where the Migration Advisory Committee, in all their work on the new migration policy, was very clear that at the heart of the problems with the social care workforce, which undoubtedly will be exacerbated through the migration changes, was poor terms and conditions, which linked directly to a lack of funding. And so we have in development an NHS People Plan. You are Secretary of State for Health and Social Care. we have no social care workforce plan. Apprenticeships that starts in social care have halved over the last year. Many of the staff are on national minimum wage, and we have rocketing very high turnover. So what is your responsibility in the context of a changing migration policy to provide leadership on the social care workforce?
Well, of course this matters, and it's important not just in terms of immigration, but you're quite right to raise the broader issues. Now, funding into social care has risen in cash terms by 11% over the last 4 years, and that's obviously a good thing. And you mentioned the national living wage, because one of the issues in social care is what I regard as skilled jobs being done by people on the national minimum wage, as was, and now the national living wage. I'm a huge advocate of the rising national living wage. I was a big champion of it being brought in. And even though it has a fiscal impact on my department, I'm a fan of it going up because one of the solutions to social care is to ensure that there is a more highly skilled, highly paid workforce, and that we don't just rely on absolute rock bottom wages. And some social care providers do this and do it brilliantly, but it is tough and the margins are very tight. And this is why we need that long-term solution that we're committed to provide.
Right, thank you. I'll take a coronavirus question. I will take it from a journalist. Victoria?
You don't have to say journalist with such feeling.
I care about it. 40 years I spent doing it.
Victoria MacDonald from Channel 4 News. There are at least, I think at the last count, 13 schools that have decided to close down. You have consistently said that they don't need to do this, but does this not suggest that they are not trusting your advice?
No, we've said that there does not need to be a mass closure of schools, and that the individual decision is, of course, for the head of that school, and they should take into account the professional advice that is being provided through the regional schools commissioner system. It's very important that, of course, schools will and want to protect the health of their students, but we've got to do that with decisions that are driven by the science, and that's why we've put in place the advice for schools when there are pupils who have tested positive for coronavirus. So we've made the advice clear. I entirely understand the desire of every head in the country to ensure that their pupils are safe, and what we have to do is make sure that the advice is available so that they can take on board that scientific advice.
Chris? Oh, sorry, I have the microphones on, coming that down here.
Chris Smythe from The Times. Professor Whitty talked earlier on about if we do get to a pandemic situation, you might need to think about measures like shutting down mass gatherings and so forth, but it would depend on how much disruption society was willing to put up with to ease the pressure on the NHS. I mean, when it comes to things like, getting rid of the end of the Premier League season, London Marathon, whatever it might be, how much disruption do you think the public is prepared to put up with if we get to that situation?
Well, we want to minimise the social and economic disruption subject to keeping people safe. And of course, that's always going to be a balance. And we're going to be led by the scientific advice into what works. And I think Chris was very wise when he was describing that there are some measures that might sound like a good idea, but don't have a scientifically advised benefit. And they're the things we really need to avoid. And then there's another group of things where they may have a benefit in terms of keeping people safe from coronavirus, but they also do have an economic and a social impact. And there we have to balance those in order to keep people safe.
Nigel, I'm running over a bit, but that's permissible, isn't it? Yep, right. Hand over there.
Thank you. Hello, Emily Morgan from ITV News. Given the seriousness now of coronavirus, there is obviously huge public concern about it. There is also huge public confusion about the advice being given to individuals. Isn't it time now that the Prime Minister came out to reassure the public and set up a task force to deal with it?
Well, we have a very clear governance system in government for how we are dealing with this crisis. I am updating Cabinet. I obviously speak to the Prime Minister regularly on this question. And then I'm chairing a weekly COBRA which brings together the cross-government response, because many of the responses are outside of the department, and I chair that weekly cross-government COBRA meeting. So we have the governance in place. We have a drumbeat of COBRA meetings and meetings with the Prime Minister and reporting into Cabinet, which is how a government should function in order to deliver the very best decisions based on the science to keep people safe.
Fantastic. I'll take two more questions, if they're short, and ideally not about coronavirus. There's a white shirt there with a hand up. Sorry, I can't quite see who it is. The lights are...
Hi, Lawrence Dunhill from HSJ. Can you give us an idea when the review into the waiting time targets is going to be published, and any clue as to what's going to be in it?
Well, this again is going to be clinically led, the clinical review of standards, I presume you're talking about, which Steve Powis is leading on, and we expect to publish in the coming months. It's very important here that we make changes. If we make changes, then we make the changes that are advised by the clinicians to improve flow and improve patient safety, at the same time ensuring that we have the accountability that I was talking about earlier, that is so important, and ensure that we if we make changes so that they improve the way that emergency departments can operate.
One more. Yes, there.
Naomi Fullop, UCL and Whittington Health NHS Trust. Really pleased to hear about your focus on service and the service aspect of the NHS. We're going through a winter of the poorest performance of the NHS, figures just published this week. Everybody in this room will either have experienced or have family members and friends who are struggling to get to see their GP, who have elective surgery cancelled, who are waiting for long times on trolleys in A&E. How do you think that relates to building public confidence? Yeah. What's your responsibility and what are you going to do about it?
Yeah, so these are, of course, important parts of delivering good service. I mean, emergency departments actually, in terms of their performance, have been seeing more people than ever before. There's 1 million more people. This is a question of increased demand, but of course it then leads to challenges in terms of access. The point about public confidence is that yes, waiting times are one consideration, but actually when you ask the public, they're only one consideration, and making sure that people get high quality communication, both about waiting times and the process, but also about their treatment, is the top cause of complaints, and making sure that staff are well supported and have high morale is actually also extremely high. So we should not judge the NHS simply by one performance metric. We should judge it by the overall benefit that it gives to the public and in particular patients. So I'm determined to tackle the performance issues that you raise, and the increase in money going in and that increased hiring is going to be very important for that, and harnessing all the modern technology that we can get our hands on that works, but also making sure that is done in such a way that patients feel the benefit in the service that they receive.
It's great. Matt, thank you very much. It's been very good to have you here.